Good Monday morning, everybody. So today, we'll just get right into it. So today we are talking about the MTHFR gene and its variants. If you don't know what that is, that's okay. A lot of people don't. Methylene tetrahydrofolate reductase, MTHFR, also known in nursing and medical circles as the mother effer gene. It's easier to remember. Methylene tetrahydrofolate reductase is the gene. Okay, so it is a gene. Morning, Linda. So the deal with MTHFR is, should you be tested for it? Blah blah blah. Well, maybe not. I've seen the incidence of this genetic variation range anywhere from 25% of Hispanics, 10 to 15% of North American Caucasians, but I've also seen it as high as almost half. I guess the big problem is whether or not you have a variation that can cause trouble. So let's talk about what it is. It's a gene. We carry two copies of MTHFR, one from each parent. And what it does is tell your body how to create an enzyme that breaks down the amino acid homocysteine. So I used to use a lab called Health Diagnostics Lab, which was then bought out and became True Health Diagnostic Labs. And part of their kind of aging profile was to measure the MTHFR to see whether or not you were homozygous, meaning you had the actual variant gene, two copies from each parent. Because if you did, you can't methylate things. That includes some medications. And more importantly, you can't methylate folic acid, which you can eat. Most people get their folate and folic acid from eating. You can also take vitamin folic acid. But in order for it to get into the blood-brain, across the blood-brain barrier, it has to be methylated. And people that are homozygous or carry copies of the mutation of the MTHFR gene, there's two, can't do that. And folic acid is really kind of brain food. So it helps you with serotonin production. It helps with dopamine production. So if you can't methylate folic acid in your body, you theoretically are higher risk of cognitive dysfunction, one of which is Alzheimer's disease. Okay, so the amino acid that needs to be broken down is homocysteine. So probably a better way and a less expensive way to check if you have a problem is to do a homocysteine level, which was part of that Health Diagnostic Labs thing. So we measured that. We measured the homocysteine level as well as checked for the variants of the MTHFR gene. And if they weren't there, then there was not a problem. So the DNA code for any gene can vary. So if it's part of a sequence that is different, it's called a variant. And you're trying genetically to determine whether or not you have a specific variant that can cause harm or benefit to health. So it's not always harmful to have a variant. So the two variants that have been studied the most, and this is just a big gobbledygook of letters and numbers. So the gene variants for MTHFR are called C677T and A1298C. That's what's been studied. So again, 25% of people who are Hispanic have that variant. 10 to 15% of people who are Caucasian have two copies of C677T. And if you add the A1298C variant, that's, I think, where they come up with the almost 50% of people have some type of variants. So if you have a normal gene and then you have a variant gene, so a normal parent gene and a variant parent gene, that may not be a problem. If you have the same variant gene from both parents, that's when you can't methylate. And then if you have one 677T gene from one parent and then the 1298C gene from the other parent, that seems to have the same effect as if you have 2 copies of the variant gene or 2 copies, one from each parent. Okay, so what does it mean? What's the problem? Okay, so if you get homocysteine levels that are elevated, that increases your risk for blood clots, venous thromboembolism, and heart attacks. Okay, and there's also some cognitive dysfunction, like you just can't think as well. So very high homocysteine levels are fairly rare, though. And that's fairly rare, just having those 2 common variants. So the homocysteine level may or may not be a problem. It's a simple blood test. If you get a high one, you start looking for things that cause high homocysteine. And the things that you can find for that, you can evaluate. So things that cause high homocysteine levels are dietary deficiencies of B12 and folic acid, thyroid disease, diabetes, high cholesterol, inactivity, physical inactivity, smoking, obesity, high cholesterol levels, all can impact homocysteine. Okay, if they're not explained by those factors, so if you get evaluated for that and you don't have any of those, that's when you do the MTHFR genetic test. Okay, so again, if you have the variant, you can have normal or elevated levels of homocysteine. The problem is that you can't methylate folic acid. So if you are homozygous for those variants, you can eat all the salad and fruit and all that you want for folic acid, and the active form is methylfolate. Okay, so the overall risk associated with those variants is fairly small. So most like the American Heart Association, the American College of OBGYN, do not recommend routine testing. And well, you may not know that pregnant women are told to take folic acid, I think 4 milligrams a day in the first trimester of their pregnancy, and that helps reduce the risk of neural tube defects, so spina bifida, etc. Anencephaly, the worst one. So when I was practicing obstetrics, that was a routine. You take your folic acid, and then I learned about MTHFR probably 6-7 years ago. And I started realizing, well, there's probably a lot of pregnant women that took folic acid and didn't do anything. So if, almost half of people have a variant, are they actually getting the actual folic acid thing? Okay. So high homocysteine levels, symptoms, is usually not there. So it's not really a symptomatic thing. They can be subtle, they can vary. And most of it is from vitamin deficiency. So of course, if you can't methylate your folate, then you have vitamin deficiency technically. So B12 deficiency, which we treat all the time. People want to take B12 shots and take B12 because they feel better, it gives them energy, it helps them lose weight. So a vitamin B12 deficiency can lead to anemia, one of the various forms of anemia. You can have pale skin, weakness, fatigue. I keep telling people the most common complaint I hear is I'm sick and tired of being sick and tired. So fatigue is a biggie. And there's so many things that can cause fatigue, it's kind of hard to figure out. Sometimes, not always. Tingling sensations like pins and needles in your hands, arms, legs, feet, dizziness, mouth sores, mood changes, and then folate deficiency, also subtle but similar to B12 deficiency. So fatigue, again, tongue swelling, growth problems, mouth sores, and then there's vitamin deficiency anemia that can overlap with those of B12 and folate deficiencies, causing additional symptoms. So you can screen for that by the size of your red blood cell and the amount of red blood cells in your blood in a peripheral blood smear, or CBC, complete blood count. So those signs and symptoms, again, they're typically subtle. Fatigue, muscle weakness, some people are unsteady in their movements, pale skin, some personality changes, shortness of breath, some dizziness, irregular heartbeat, numbness or tingling, mental confusion, weight loss. Okay, okay, so those are all fairly subtle, there's so many things that can cause all that. So you really have to kind of listen to somebody, and they'll usually clue you in on where to head. So as a health coach or a physician, most of what I glean is from listening to people tell their story. And if I get their story, I can usually figure out where the fatigue is coming from. Blood tests are usually involved as well. Okay, so if you have folate or B12 deficiency, you may develop hyperhomocysteinemia. So it's fairly rare, but it can cause that elevation of homocysteine in the blood. The other risk factors, again, low thyroid hormone levels. So thyroid for fatigue and weight gain is just a routine. You check thyroid. You can't just do it with a TSH. TSH doesn't tell you a whole lot by itself. So remember, the active thyroid hormone is free T3. That's the one that's active in the cell, and it has to be converted by your body from free T4 to free T3. Are you getting that? Okay, psoriasis can do it, kidney disease. There are medications, specifically statins, fenofibrates. There's several different medications that can affect homocysteine, vitamin B12, and folate. And then, of course, the genetics, which is the MTHFR gene. Okay, so what does that gene do? Okay, so folate occurs in natural foods. Folic acid is fortified in our food, but they're not using methylfolate. This study is showing 60% of the population in the U.S. has some genetic variation that makes them unable to utilize folic acid and folate. Okay, they do not allow the MTHFR enzyme, which is coded for in that gene, to function properly, so methylation of folate does not occur. Okay, without that, folate cannot be used in your body. There's some negative health effects that we just went through and possible inability to maintain a healthy, happy mood. Okay, so folic acid, the most common form of folate in supplements and fortified forms, has to be converted in the body to L-methylfolate. Okay, so MTHFR is the enzyme that does that, coded for by the MTHFR gene. Okay, so people with those genetic variations, supplementing with already activated form of folate is way more effective. Okay, so typically people take folic acid and supplements that are not methylated. They do make L-methylfolate, and the typical dose is 5 to 10 milligrams. About 10 milligrams for people who have that genetic variant. But to me, I usually just tell people, just take L-methylfolate. That's the active thing. I mean, you're taking your supplements anyway. Just take an L-methylfolate with the other however many supplements that you take, and then you know that you have the activated form of folate in your body. That way, you don't even have to do the MTHFR genetic test to see if you're a variant. Just take L-methylfolate, right? Okay, so the other forms of vitamin B9 are folic acid and folate. So folate's often called a natural form of vitamin B9, but it's really a family of compounds that occur naturally in vegetables. Okay, so folic acid is a synthetic version of vitamin B9. Typically, the first line of treatment for anybody that's folic acid deficient. And any folic acid we ingest, though, again, has to be metabolized into dihydrofolate and then tetrahydrofolate and then finally into L-methylfolate for it to be used in the body. And once it's transformed in that way, it can be transported into cells and tissues, and this is the form that crosses the blood-brain barrier. So people that are MTHFR gene variant people who don't methylate folic acid, if you do a cerebrospinal tap on them, you will find lower levels of folic acid. And some of the things that cause some of their mood problems. Okay, remember, this is serotonin, dopamine, melatonin, epinephrine, norepinephrine. Okay, a lot of the neurotransmitters require L-methylfolate for brain chemistry. So it's the responsibility of L-methylfolate to help produce those neurotransmitters. Serotonin, so remember, everybody's taking selective serotonin reuptake inhibitors. How many of those people maybe have a genetic variant? And all they possibly need is L-methylfolate and not have to take Prozac and Paxil and sertraline and all that. Melatonin, remember, has to do with sleep cycles. Dopamine is your pleasure center. Epinephrine and norepinephrine are important in synapses between nerve cells. Okay, they're involved in short-term memory, concentration, sleep, motor control, hormone control, mood stability, motivation, and appetite control. Okay, so low folate levels associated with mood disorders. Just try L-methylfolate as a first-line therapy before you start getting stuck on Prozac for 20 years, right? Okay, so homocysteine, those people with the genetic variant of MTHFR gene can have high homocysteine levels. Okay, and so once again, that leads to B12 and folate deficiency. Just take L-methylfolate probably and get evaluated for, if you have high homocysteine, just get the blood test and figure out if you're in that range, and look at all those lifestyle factors and other medications that might have something to do with folate metabolism, specifically the statins. And we spent how much time talking about statins about 2 months ago. Okay, peripheral neuropathy. So people that have, and this is usually, not always, but one of the problems with type 2 diabetes is peripheral neuropathy. And so L-methylfolate supplements can help promote healthy peripheral nerve function based on those neurotransmitter formations that we just talked about, right? It also, and you heard me talk about nitric oxide about 2 weeks ago, helps support increased vascular nitric oxide production. So remember, there is some elevation of risk of thromboembolic clotting. And clotting, of course, is involved in myocardial infarction or heart attack. And so improving vascular health with L-methylfolate by nitric oxide production is helpful. And taking nitric oxide, remember I was drinking my nitric oxide 2 weeks ago right here on Facebook doing that. Okay, gout, another condition that usually involves the first metatarsal joint of the foot, so your big toe. But other joints can be commonly involved, and L-methylfolate helps metabolize uric acid. Gout is a deposition of monosodium urate crystals or uric acid in the joints and soft tissue. That's part of a typical complete metabolic profile is a uric acid level. So people that run a little bit high, I tell them probably ought to take some L-methylfolate just to keep your uric acid from getting too high and getting those deposits in your toe. My dad had it. It was horrifying for him. So if you've ever had gout, you know what I'm talking about. It's very bad, very painful. So that is the reason, if you've heard of MTHFR, those are the things that people that pay attention to that are looking for. To me, you don't need the genetic test, just take L-methylfolate. It's fairly simple. I think that would probably rectify a significant number of problems for a lot of people, right? So what we'll do is, I told you last Friday that we would get into pharmacogenomics. That's a test I think everybody should have. And then coming up down the road, we're going to talk about food intolerance and food sensitivities, easy testing. There's actually a food intolerance test that has gotten quite a bit less expensive. It used to be when I would run ALCAT tests on people for food sensitivities and insensitivities, it was a $600 test, but you knew exactly what you were sensitive to, even what you were breathing that you were sensitive to, like trees and different stuff in the air. So we'll kind of move forward into some of those issues. So MTHFR, you don't need the test necessarily. Homocysteine level, not a bad screen. But remember, even the people that are variant rarely have high homocysteine levels. Again, probably the easiest thing to do, make sure that your B9 is not deficient, is to take L-methylfolate. Then you don't have to worry about your gene, right? Okay, so I will see you Wednesday morning, 9:30. One of those things I just talked about is what we'll talk about. My guess is pharmacogenomics. That might take a couple different classes. So have a great week, great Monday, and peace and health to all of you. And I'll talk to you Wednesday. See ya. Bye.